We'll start in 30 seconds here.
Stefano,
Hello, good morning.
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 Oh, yes, and some it's evening, so good day.
Good day.
Hi, Mladen.
Hi. Aladdin, hi.
Hi, Antonio. Right, I'm gonna have to jump around to a meeting.
আপনি কোন সময় ফোন দিয়েছিলেন সেভ করা ছিল?
My thoughts exactly, Mohammed. Welcome, everybody. Going to get started. Several people with a bit of tight schedules. Some of us will be able to stay the whole time, not everybody. And welcome, and I'll show a picture of who's invited here. And you've already seen this, but the quick version of this, with apologies to Alexandra Limgruber, who hadn't agreed to be on this list, but Toby has. But we've got champions to these capacity building and impact teams, and then 2 co-leaders. Looks like of those 6 leaders for the 2 groups, 5 are able to be with us today. I'll follow up with Shauna. And we've got these perspectives, you know, from hospitals, health systems, ministry, academia, industry, including ISOs, regional overview and societies. And we've got support teams around from CED and GCEA. So welcome to all of you. I'm not going to do the introductions to go time, to save time. We're, as I was saying, some of you just joined, we're going to jump right in. We did have that, many of you seen the transcript, I think this is it, of we weren't trying to exclude anybody, you know, so there's 2 10-person teams, right? And there's some people around those 10-person teams. And we wanted to sort of start this meeting, this first meeting of the 2 teams, which could have been separate meetings, but you know, it just worked out for people to do it at the same time here from 10:30 to 12 New York time today. So we did do this, try to get a running start with this meeting here on March 11th. And I'm going to summarize that in a moment. And I'm going to shut up and let you guys talk too. It's not about me. But I just want to set the table here very quickly. One thing we just, you know, we discerned from the getting a running start meeting is that, you know, this is a complex topic, and capacity and building and impact measurement go together. Antonio described, and many of you read this transcript, that, you know, there's a continuum, there's a subset of activities that we could describe, you know, the elements of what makes up CEs. We'll look at that in a moment, or CE body of practice, you might say. But, and people are at different places on that continuum in their body of practice. You might say lesser resource earlier in the stage, could call that a yellow, you know, like a stoplight. I mean, a red stoplight. And there's those that are midway along in their development. You could call that a yellow stoplight, and those that are very advanced in their element of that kind of CE activity, call it a red. I'm covering a lot of things in a hurry here, and I know we're going to catch up here and have longer time to explain some of these things. So I've just described there's a continuum. We're going to see where people are on that continuum. We're going to try to help them move to more advanced capability within that, you know, continuum around a certain element of the body of practice. That's part of capacity building. You know, we said enough of the right people with the right education, training, and appropriate management skills it's deeper and wider than that, but as we've got to apply this to certain real topics, and I'm going to talk about those in a moment. And the draft overview I sent, we applied it to pulse oximetry work at home in UK, but we're going to maybe choose a couple other examples today that are different places on the, the different kinds of audiences and different kind of customers. Antonio not only reminded us about these CE activities that we've somehow got to characterize at our previous meeting, but also, there's 3 levels that they might be applied at. There's the local level, the local hospital. They could be applied nationally if there's, maybe a society leading things that works on those things across a country, and then they could be applied globally. And so a set of activities applied at 3 levels. And even when you think about local, a local solution to how HTM is done, maybe of pulse ox, could be, there could be many stories about that. Some hospitals in a country, one local situation is not equal to another local situation. So there can be many stories around that particular topic. And we know that, but we can still figure out a way to characterize. So set of activities, 3 different levels. And we said, like I'm starting to put you guys to sleep, particularly the early ones in the morning, 7:30 out there, Carla. Sorry. Hope the coffee's good. But if we applied those things to a case study like, a hospital-based program that sends out appropriately vetted pulse oximeters for patients to use at home that may prevent hospital stays and, knowing when to go get further care across a wide population. So what's my point? If we apply these activities and these levels to a case study, it becomes interesting, it becomes real, it becomes relevant. And in some cases, we've already got an outcome study of how it, decreased hospital stay, length of stays, and, improved clinical outcomes in some fashion, which is our impact measurement side of our equation. So summarizing, so that was a lot of what came out of the transcript that we sent out ahead. And then just before this meeting, I sent out this overview where, it's important, as we know, to define what do we mean by clinical engineering? What do we mean by a clinical engineering set of activities? I can just quickly say we've tried very hard in CED and the Global Clinical Engineering Alliance, GCEA, to reference ourselves from WHO's definitions. And that's, we could perhaps debate all that. Don't really have a lot of time for it, but, I think, so just know that we've come from WHO and not, some other source as we try to define who clinical engineers are and what clinical engineering body of practice is. We tried hard on that. I would say in terms of, so that's a first point. A second point is, what are the CE activities? And Dan, I'm going to turn this over to you in a second. I know you don't have too much time. We tried to say, well, what do you mean by CE activities? Or, okay, the competencies. Okay, well, after Rome, we defined 10 competencies, and you can see them here. And then we did a little brainstorm since then and said, well, that's missing some things that are important. And so we've come up with a dozen more, and these are not necessarily exhaustive, these 22 items. And we can explain those if they're not as clear. And so, Dan, let's pick your brain for a few minutes. Tell us what maybe is clear from the stuff I've shown so far about your work. And I know you have already said, Tom, I don't know everything, and I don't know the answers to all the questions. And so, and A, you're humble. B, nobody knows the answers to all those. So I am going to give it to you in about 15 seconds, but have you tell us about this particular case study. But I will say ahead, this case study, where HTM and HTA and a lot of other things come together in a powerful, relevant way that's happening today. It's a hospital-based program, but it's working with a population around that hospital and, trying to keep them safer during COVID times. We're probably going to introduce 2 other case studies today. who appeal to maybe a broader audience of clinical engineers around the world. This doesn't necessarily fit into the traditional medical device management in a hospital paradigm. But if we said took on ventilators, which particularly us in the first world, we've been working on ventilators for a long time. That's very relevant, obviously, during COVID, if they're used appropriately. And we, our African friends have been wrestling with oxygen concentrators and Asian friends and others. So we might pick 3 case studies, but let's start talking about one of them because we want to apply, the notion of where are you on that capacity building continuum and what's the impact at the 3 different levels. What's the impact of, our provision of the services we provide to the delivery of care in those settings. But once again, it becomes more interesting if we apply that previous conversation to real life projects. So Dan, tell us about the National Health Service UK pulse oximetry at home program.
Tom, thank you very much. Good morning, good afternoon, good evening, good night, wherever you are in the world. It's nice to be with you today. I'm happy to talk. Tom, did you want me to share my screen, or do you just want me to talk for 2 minutes?
Yeah, let me give it to you.
I don't know.
Yeah, I'm giving it to you.
I'm not on my own computer, so this could be exciting. Let's see what happens.
And thanks for fighting against all the firewalls there in UK.
Yeah, it happens. So, am I now sharing my screen? Because it's always a bit confusing.
We can see it.
Brilliant. So I won't take too much of everybody's time here. Tom and I had a discussion along with a couple of other people about the idea of using a number of case studies to illustrate the impact clinical engineers can have, as Tom said, both locally, regionally, nationally, and indeed internationally. I'm not absolutely sure this is the greatest case study, but it's one that might work for us, and we can find others. And the rest of this afternoon, you boys and girls are probably going to talk about other case studies that we might use. But we thought we'd kick off with this one just to give you an idea of the way we were sort of thinking. So this was a project that we got involved with as clinical engineers, a national project in the UK. It was focused obviously around COVID. And what happened in this instance, and bear in mind this is right back at the beginning, quite close to the first wave, soon after the first wave of COVID had started in the UK, and I think that we noticed, the clinical colleagues noticed. I'm going to skip over this slide. Clinical colleagues noticed that when patients presented in the hospital, their outcomes. COVID patients presented in hospitals, their outcomes were hugely dependent on their oxygen saturation at the point at which they presented. So a clinical study was taken place across several hospitals in the UK, which essentially showed that the lower your oxygen saturation was at the point of presentation, the worse your outcomes were likely to be. So very roughly, the graph at the top right hand corner of here, it's not scientific, but it roughly demonstrates what they discovered. If you presented as a COVID patient with an oxygen saturation level of about 94 or above, your outcomes were relatively good. As your oxygenation saturations dropped, your outcomes plummeted hugely. The bottom graph, the bar chart there, shows 95% and above on presentation. Your outcome, your death or length of stay in 30 days or more in the ICUs was about 5. You had about a 5% chance of dropping into that. If your saturations dropped to 93 to 94, your chances of dying or staying 30 days or longer in ICU went up to about 10%. If they were below 92 on presentation, your chances of dying or having a 30-day stay in ICU went right up to nearly 35%, so a massive impact. And what they discovered was a condition which we now refer to as silent hypoxia. So patients with COVID staying at home, not presenting because they felt relatively well. All right, they knew they had COVID, they knew they were a little bit poorly, but they felt relatively well. And 1 or 2 or 3 or 4 days would pass and they were getting more poorly, but they felt relatively well. And what they hadn't realized was happening was those patients' oxygen saturation levels were dropping. I mean, really dropping down to sort of 93, 92%. And at that level, they suddenly realized that when they walked upstairs to go to the bathroom, whatever, they couldn't make it upstairs without becoming breathless. And that's what this study showed. It showed that there were huge impact on these delayed patients coming into hospital, huge impact on their expected outcomes. So as a result of that, a project was started to issue patients in the community in their own homes with pulse oximeters. And if you're the patients were then instructed to measure their oxygen saturation levels, and if their oxygen saturation level dropped below 94, they must present to healthcare organisations. So they issued lots of these cheap and fearful pulse oximeters, the sort that you can see on the screen now, the sort that you can buy online from Amazon or similar online stores for a few dollars. Really, they're cheap devices. And they issued thousands of these across the NHS. Clinical engineers, as a profession, got involved at this stage in quite a negative way. Well, not a negative way, but we were starting to advise the national project that these cheap pulse oximeters that they were using were really not very good. They weren't anything like as good as the devices that we would use in a hospital. And particularly, they were pretty poor at measuring oxygen saturations when that saturation dropped to the levels that they were interested in. So we were advising against using these pulse oximeters at the outset, but we were at least involved in the project and talking to the clinical leads. So they issued all of these, and despite our advice, they found a huge success with this project. There's been a number of papers written on the outcomes, and some of the data is astounding. You know, in one area alone, we avoided in a 3-month period something like 1,000 hospital admissions, just in a 3-month period. We reduced the length of stay considerably from, I think it was 17 to 10 days when they were using home oximetry. And once the patient was in hospital, we were able to support much earlier discharge into the home environment. So the project was hugely successful from a clinical outcomes perspective, so much so that it was rolled out right across the NHS, and indeed it's been rolled out in other countries too. The lead has been taken in a number of countries around the globe. So clinically, this project was hugely successful. Clinical engineering wise, we were unhappy that they were using cheap pulse oximeters, which didn't come up to the accuracy that we would normally have expected. So we found this a challenging project to be involved with. We were unhappy or concerned that they were issuing these devices to patients which were not as accurate as we would want. And one of the lessons that we learned throughout this was that it was much better for us to support this project. Given the success and the urgency of it, it was better for us to support this and make sure that they got the best possible devices amongst these less accurate devices. And we learned the lesson that in a circumstance like this, you know, good enough and doing it quickly was better than getting it as good as possible, but doing it later. So we supported the rapid rollout of these cheaper devices. We found it very difficult to manage the equipment because we were talking about hundreds, thousands of devices being issued to patients in the home environment. We are clinical engineers. Historically, we're used to dealing with equipment in our own hospitals, where we know where it is and how to get hold of it. So this was a challenging area for us to change our practice and change it very rapidly. And we were concerned all the way through this, that they were issuing devices which were not accurate enough. We did a number of studies, and we supported some other studies looking at the accuracy of these devices and how they became less and less accurate at lower and lower oxygen saturations. The graph in the bottom right-hand corner of this chart is just one example. It's not my data, it's data I've used from somebody else's work, but just demonstrating that these devices become more and more inaccurate at lower oxygen saturations. But despite all of that, this project was successful, and it was successful partly because we warned them that these devices were inaccurate, and the clinical project put in a range of other measures to make sure that the patients were not overlooked if the oximeter was inaccurate. So it was challenging work, but it was a work that got clinical engineers involved in a major national clinical project, and we were able to influence that project for the better. So Tom, I don't know if that very rapid run over that project was the sort of thing you were hoping for today. I think it is a project that shows that clinical engineers have to be flexible. We have to adapt our practice to meet the clinical need. One of the key lessons I think that was important that we learned was that we can't always Now, we're engineers. We work to the second or third decimal point very often. And in some circumstances, being that precise and that pedantic about the accuracy of the devices wasn't helpful, and we had to be a bit more flexible and support the project in other ways. So that just gives you a quick overview of how we got involved with that national project. We may be able to come up with other case studies, but Tom, I think you wanted one to kick off with so that people could get thinking about how clinical engineers can influence and have an impact on regional and national projects.
Great, Dan. So just go with these, our competencies that we did the webinars in 2020 around, and maybe at high speed go down. Well, I mean, so HTM, you know, so what the heck are we talking about? And, you know, that's typically life cycle management of medical devices, hospital-based clinical engineering departments. So NHS Nottingham, you got a bunch of hospitals and a bunch of clinical engineers, right?
Yeah, absolutely. And we do an awful lot of HTM, as you can imagine here. We look after 70,000 plus medical pieces of medical equipment. And in this case study, I mean, perhaps you don't want to talk about this case study, but yeah. So we consider ourselves, you know, experienced and with considerable expertise about managing the life cycle of medical equipment throughout our hospitals. We have a pre-planning stage where we look at the compliance and acceptability of equipment. We have a planning stage to decide what equipment our hospital needs. We have a commissioning stage, looking at making sure that the equipment that we bring into the hospital is compliant, safe, and working correctly. We have a deployment stage where we make sure that the clinical staff know how to use the equipment before we put it into clinical service. Once it's in clinical service, we support the clinical teams with asset management, with maintenance and support of the technology itself. If there is problems with the equipment, obviously repairs, servicing, but also incident investigation if they're involved in incidents. And then we have a decommissioning phase where we look at the obsolescence of the equipment, when it's reached its end of life, when it can be replaced. And then we start the whole process again, looking at the planning stage.
So Dan, how many people in the, you know, what we would call here the catchment area of Nottingham? How big is the population you serve?
Oh gosh, well it's so the direct population of Nottingham acute services is probably a shade under 1 million people, but we have some specialist services and we have a regional trauma centre, so that throws the population for those specialist services probably out to about 2.5 million.
And how many NHSs, I mean, just for example, across the country, I mean, how many Nottingham-like places are there?
Well, Nottingham is one of the biggest in the country because of the geography
Everybody knows about Robin Hood. They're from Nottingham.
Yeah, absolutely. Thank you very much. I'll send you the pictures of the big tree. Yeah. To be honest, I don't know.
That's okay. You don't have to.
Yeah.
So where I'm going with that is, I mean, you're a local answer and you're part of a national answer because this is a national program. So how do clinical engineers, how does that team there at Nottingham maintain pulse oximeters? And Elliot was reminding me that I think that's in the new videos, you know, how to buy, select, maintain, obsolesce a pulse oximeter. So I guess you guys do something like that?
Yeah, for sure. So we have a team in Nottingham. My entire service team is about 110 staff. About 60 of those will be technologists, technicians, who will be supporting all technology, not just pulse oximeters, of course, but a whole range of medical device technology in the hospitals and surrounding communities. So we have a number of workshops, obviously test equipment and test facilities, and we have allied clinical staff that work with us to support clinical applications of medical devices. So
let me just start with Frank and Antonio. Any questions you guys, Dan's got another meeting in about 10 minutes, but while we got him, any particular, and Saba in just a minute. Frank, sort of an immediate thing as you think about that from a capacity building?
Yeah, I really appreciated Dan's presentation. It gave me a little more clarity. I was in the challenge of leading the capacity building group, and given the definition that was printed on the chart with the people who are participating, it led me to believe that we were looking at one definition of how to build the capacity of clinical engineering services across the world. And I realized that that was wrong. It really, there's different levels. There's, like low maturity programs, low maturity in the healthcare system, low maturity in resources, medium and high. And Dan's system is obviously a high resource, clinical engineering is highly accepted. Clinical engineering is part of the healthcare delivery team. And this was very interesting to learn about how clinical engineering could be more integrated into the effective healthcare delivery system, and how we need to maybe not be engineers, but sort of be team players and come up with, providing the best possible answers to the clinical problems at their level using their number of resources, and not come up with all these perfect solutions and the perfect vendor and the perfect answer. We can't do that. So how do we build capacity in a highly developed system? Dan nailed it, but the discussion can go on. The discussion can be, much more developed, and other examples used. Yeah. So this, sorry to talk so long. I finally clicked, so I'm
That's
excited.
why we're paying you the big bucks. Go ahead.
Yeah. So this pulse oximetry example is a very good one. I don't see how it applies at all to low resource settings or to medium resource settings, but it is the answer for coming up with solid recommendations for capacity building in high resource settings. So thank you, Dan.
Antonio?
Yes, Tom. First, congratulations, Dan. It's a great work. However, I am in a dilemma in how all this work could be put together.
And we're going to take the next hour after he leaves to talk about that, but go ahead.
Yeah, and because there are two things in the past, this group, a larger group, documented under Tom leadership, successful programs or activities in different countries. And now we are starting case studies to document very important developments. And that is a way to document impact based in successful or probably not successful study cases. That is activity-based in a specific environment, but and could be seen globally as an examples to follow. However, my dilemma comes when I am questioning what is happening in the less developed world with less access to resources. But however, through the time and with the support of external groups are improving. So initially I was focused in that, an instrument that allows to measure impact in our day-to-day activities in health technology and clinical engineering. What is happening in a less developed country, in a rural hospital, and how they are improved, or how nationally the government and the academia is helping to develop and measure how things are changing. So with all this information, what I am trying to do is to realign this.
Well, don't forget any of that as we apply it to maybe a different case study like oxygen concentrators, that we'll talk about in a minute.
Yeah, but finally, my concern, as I say, is a document specific impact in a specific development, or having an instrument that allow anyone in any place with any platform to measure impact in the day-to-day activity. That is basically, in summary,
Very good.
my thinking.
I'm going to turn to Saba because Dr. Saba there in the Netherlands, previously in UK, has been working on those instruments a while. And I don't know, I'm not putting the pressure on you, Saba, to have all the answers to this, but what are your thoughts right now?
Yeah, thanks. Yeah, I think this is exactly speaks to what I wanted to share. I don't know if you can see or hear me.
We can.
Okay, fantastic. Listening to Dan, hi Dan, good to see you. Going
Hi.
back to the work we were doing a couple of years ago or discussing a couple of years ago, we've already established it can be very difficult to do global cross-country quantitative studies in which we look at the impact of clinical engineering. Okay, there's various reasons methodologically for that. And I myself had come to the conclusion that one of the things that we can do is look at various cases and do some kind of global comparisons and find instruments of measuring impacts that can be applied for different settings. So that really speaks to what Antonio was talking about just now. And looking, for instance, just taking Dan's example, yes, you are going to collect things like how do we influence change? How do we provide nuance to what is ultimately used in practice? How are clinical engineers involved in the process? So they're more qualitative indicators, if you like, but they can be made into indicators which you can then apply to different cases. So one of the things I wanted to bring to the table, Tom, was what do we, if we start with this, and this specific case seems to be quite context relevant, i.e. the recent pandemic and the UK context, should we be thinking a little bit more long-term about cases that might be a little bit different, but they give us similar lessons learned, lessons on influence, lessons on leadership, lessons on advocacy, lessons on how we improve quality and safety and cost effectiveness for those specific contexts, and those then are lifted up to become the instruments that we use in our impact measurement for other, for HTM or for CE generally, globally.
Good. Anybody else? Open mic for Dan here. He's got a couple minutes only.
I think he's leaving us, unfortunately. He's just me.
Yeah, I'm already 5 minutes late for the next meeting, so I'm sorry, but I can hang on 30 seconds if there was any final points for me, or I can pick up with you, Tom, or
Dan, while people are breathing here and getting to the mic, it seems like of these first 10, so this is national policy at some level. I'm sure there was some regulation involved. We could debate about digital health,
Yes.
Certainly innovation. You're certainly partnering in quality and cost effectiveness. And HTA, health technology assessment, has been brought into play. Any comments about all that, or pretty much true? A lot of the elements touched.
I could, but if there was more time, I could walk through most of these and point out. Most of them apply to this example, but not all of them. But we could certainly find other case studies where all of them apply. So,
Okay. And
I'll have to do
Fabiola,
that.
quick comment before y'all didn't get too mad at me.
Okay, thank you. Well, I think Dan has settled the standards for the documentation of the cases. We may ease our work by having as much as possible similar methodologies to describe the actions and to document these actions into a report or a paper or any kind of presentation. And this, I expect that this allows us to find out better indicators and to not to compare, but also to analyze what happened in every region. Thank you.
And Ashnafi, quick comment last.
Just are they measuring impact or outcome? But thank you for the very excellent presentation. Just a question for Dan.
Okay, go ahead.
Now that might depend on definitions. So for me, when we talk about in the clinical world, when we talk about outcomes, we almost always mean clinical outcomes, and there are some clear definitions of what they are depending on the clinical conditions. I think what we're talking about as a project here, though, is impact. And obviously, one of our impact measurements are the role of clinical engineers, the activities of clinical engineers improve patient outcomes. So the two things are different, but clearly closely related.
Bye, Dan. Thank you.
Okay, cheers, everybody. Thanks.
Tom, should
Hi,
we be
Dan.
thinking, oh, sorry.
Go ahead.
Sorry, Tom, should we be thinking about this as a theory of change of some sort, you know, like some logic model where we can think through, and this is where you can bring your contextual factors in, your assumptions, which indicators you're going to use. Use a
Well,
theory framework.
we've got a very simple conceptual framework, and I'm not trying to be too funny. You think at a higher level, and different ones on the group do than we're thinking at the moment. But let's raise that question at the end here again. I mean, at an extremely simple level was, you know, these things here on the screen define CE activities. We could debate those. You know, is there major things missing? Our CED board yesterday was saying it would be wise for us at some point to say what's not CE. You know, I don't know if we have time to work on that today, but, you know, in other words, what are the boundary lines of what we would call CE practice? Certainly life cycle management of medical devices historically. It's also, you know, increasingly management in various clinical settings, you know, from the home all the way to the intensive care unit, digital health tools, health IT tools. But, you know, we all bring our biases and our backgrounds to the table. And so it's very tricky to get that perfect. But if we define a set of activities and then look at them at the three levels of use here, which we defined as locally, nationally, and globally, you know, and then think about them. Once again, these are some of my biases coming through, 3 priority levels. Let's focus our thoughts on what is the impact, how do we build the capacity of, and what's the impact of clinical engineers in the hospital-based setting as a highest priority, but be interested in, you know, and perhaps measuring around the clinical engineer in academia, industry, and other roles like is represented around the table here today, as well as be, you know, we know that the full range of CE practitioners, we could define that perhaps, but includes from WHO standpoint, biomedical equipment technicians, you know, bring them into play. But, you know, we're starting to build this multi-dimensional object that gets a bit confusing. The way I left it reasonably unconfusing, at least in my mind, is, you know, to put answers in each of the boxes on this table here. But let me end that paragraph and start a new one. Frank very appropriately asked the question, and I'll reiterate Frank's questions here. What's the purpose and the mission of each group? What's the goals of each group, and what's the timeline? And I think this is the right time to just quickly give a short answer to that question. So this capacity building team, the team of 10 with support around them, is looking at capacity. Well, is looking at capacity building. And once again, we defined that a bit more, but we said people are in the capacity building stage, depending on their country and so forth. They're at a lower resourced end of that. I'm not talking about the country. I'm just talking about the clinical engineering capability. In other words, I was talking last week, and I don't want to talk too much here, but I'll try to be quick. I was talking last week with the Pacific Islands clinical services leader. Who are the Pacific Islands? We're talking about Samoa and Fiji and Kiribati and a bunch of other places that we mostly don't hear much about. And they said across what used to be 14 countries, 14 islands, now they're working with 22 islands, you know, out in the Western Southern Pacific. There's usually a BMET only for the island. And, you know, they're suffering, but, you know, as a result, because they, you know, et cetera, et cetera. So anyway, so we know there's people at the low resource end, and maybe what I just described, something that in my mind was at the low resource end with not so much capability. not so much direction and management, not so much test equipment, not so much ability to do the full range of clinical engineering activities with the users of equipment in their area and so on. There's people in the middle of that continuum with capabilities that have been built up, with the right management, the right connections, and the right tools over both literally and figuratively tools over the last 10, 15, 20 years in the middle. And then there's people at the high end that very advanced capability, maybe definitely describing what Dan just talked to us about for the most part. So low, medium, and high capacity building. I heard Antonio a couple of weeks say, let's identify where people are, maybe where they've come from. They used to be low, now they're medium. They used to be medium, now they're high. But let's define these activities and work such that, and maybe fill it in with stories such that we can see where their gaps are and help them move further up the continuum. And then similarly, what kind of impact are the lowest end of the capacity building have right now? What's their gaps of impact that others are showing, in the medium and the high? I hope I'm making some sense. So what's the purpose is to see where things are, where people are, where groups are, where clinical engineering capability is in, around the world, and then to be able to measure its impact, not only on clinical outcomes, but in various process measures and so on. What is a target we're aiming towards? As a first target, we're aiming towards October, the last week of October 21 to 28, October 2022. In an ideal world, maybe in a face-to-face Congress this year, and more likely a virtual one, that we can gather the results and the stories of all this and present, where we are in various places around the world by October. So let's take that off a little bit at a time. We're going to try to have an hour and a half meeting once a month of this group, whether it's both groups together, because that's just the way it turned out. We were trying to separate them, but I'm glad we're all here meeting together, even though it's a bigger group. And what are we going to do the next 3 months towards that end? I think in the next hour, if I would shut up, we'd have, got 48 minutes here. We could define, do we agree on a direction for the next 3 months? The good news is if we define a set of questions, we can hand them off to the 6 WHO regions of the world, board and collaborators from CED that you've seen. We've got 10 to 40 countries from each of the regions. They're going to start regional meetings next month, sorry. Probably the second half of April, and the first half, and over the next 10 days or so, we might define some questions for them, schedule a meeting of them, and then ask the Southeast Asian, Western Pacific, and the Americas, can you bring stories to the table that answer questions for us of the larger around these case studies? And so that's the timetable. And if we met in late April or early May next, what would we do with these answers that the regions brought to us with this data? The last thing I would say is, let's consider a couple other case studies now that we know what one looks like. And maybe this is already, has been said by Antonio and Frank, maybe this is already the high end of the continuum. The low end of the continuum, that I see a lot of traffic about, it's not about me, is all the work around oxygen concentrators. Many of you know that CED and GCA are a part of the Every Breath Counts Coalition that WHO is a part of, but it's basically 200 NGOs around the world. They meet every Monday, and it's facilitated by a colleague, Leith Greenslade, who's an Australian, but she's in New York City, but she facilitates 200 NGOs that care about COVID and respiratory equipment and oxygen and related issues every week. And they point out, the need, of course, a year ago, like the ministry or like the World Health Assembly of WHO pointed out the need for ventilators. And this year, or 2 years ago, ventilators, last year it was oxygen. So they're really working hard on oxygen. And there's a lot of work in the you know, in the LMIC countries or the middle income countries around oxygen delivery. And so, you know, maybe oxygen concentrators, which is getting a whole lot of attention in many, many different ways. We've got a lot of data we can help bring to the table about that. That would be a good case study. And maybe we can consider a third, whether it's ventilators or not. All right, enough from me. Back to you, Frank. I hope I'm answering some of your questions. And so that you can give leadership to this 10-person team.
Yes, thanks, Tom. Yeah. So I was just writing you a text message, but I think I'll just ask you in public here. Are you expecting us to, as group leaders, to take our groups and go forward and
No, no, not by yourself. You know, with a support team around you,
Yeah.
are going to help. And so
Okay.
we're going to try to set the table and just leave it with questions for you to answer. I mean, as best you can from the data you're seeing, without organizing what happens next.
All right, I understand. And so I'm just going to say that I perceive the topic of capacity building, the answers to the challenge of capacity building to be three different answers at three different levels in the low resource, low maturity, clinical engineering, low healthcare system development regions, which Antonio was worried about, and the medium, which Antonio is worried about, and the high, which is, you know, in the wealthier, more developed areas of the world. But I don't see challenges, you know, I don't see the answers being crossing too much, where some of the answers for one group would apply a little bit to another group. I see three different sets of answers, but that's great. You know, I mean, we can provide an answer to each area of need. And yeah, so that's sort of how I see it at this point.
Very good. It's time to give others of you a chance. Let me go to Baron. A is one of the co-leaders, and Baron, you know, I don't want to put words in your mouth. You can speak for yourself. You know, Nepal, maybe it's some, you know, in the capital city has what we've been talking about, medium development of clinical engineering, and out in the far reaches of the country, maybe, you know, not so much resource. How do you see capacity building, Baron, in Nepal and in the Southeastern Asian region?
Thank you, Tom. In fact, you are aware that I am actually a little bit struggling to recognize, to get recognition of our this society, biomedical society here in Nepal.
They're creating a new society in Nepal, but go ahead. Yeah, yes, sir.
Yes. And we have applied to get registered in IFMB CED to
well,
to
register
have
within
collaboration.
IFMBE. CED, you're welcome with open arms years ago, but IFMBE, you have to pay money, blah, blah, blah. Go ahead. I'm just clarifying things as you go, but keep going.
Yes, thank you for that. And but still like there are so many documents and things that we need to provide there, but these all are I'm trying to do is to do the collaboration and get support to have some activities or in many kind of things for the national level. And for the especially for the low and middle income countries and developing countries, we all know that biomedical sector in itself is very backward, and now with the COVID, it is emerging a little bit nicely.
Well,
But still,
Baron,
we
let me
have
ask you a specific question, because this is family here, you know, so I'm reaching over you to get food from across the table here, so to speak. You were involved with the Ministry of Health Nepal getting a maintenance program going for public hospitals. Tell us a little bit more about that, because that's capacity building at its heart, I think.
Yes, before that, actually, all the biomedical engineer, service engineers, the hospitals were importing from India. and when we started the maintenance project, nationwide maintenance project, then in the beginning we have very few service engineers who are competent, and because so many biomedical engineers and technicians were involved, and then there were skill transfer, and then they got the to get explored, and then they learned so many things, and then now we have so much in-house capacity for the servicing of medical equipments, also for the procurement or much more development because of that project. But still there are so many things, I think, because now the maintenance project is now again stopped, and again hospital and health facility are suffering for the maintenance and all.
Very good. George, talk about Ghana. You're in you're in Africa, and you're at one of the more progressive countries in Africa. You've got a recognition of clinical engineering at the Ministry of Health level in your country. What's your reaction to what you've heard in capacity building for Ghana? And happy birthday, by the way.
All right. Thank you, Tom. Hi, everyone. Capacity building in Ghana, I would say, it's not all that impressive. We've had a little capacity building activities here in Ghana. The key among them is we have an organization that is KOFI, Korean International Federation on Health. They have been helping Ghana, the Ministry of Health, Ghana Health Service, developing capacity, especially for clinical engineers. They have other areas that they are working, but they are organizing clinical engineering management activities for biomedical and clinical engineers. So what they normally do is once a year, they organize a meeting, 1 week training for clinical engineers. This has been run for the past 3 years. And somewhere in 2017, the Ghana Society of Biomedical Engineers, also through the help of another international organization called Assist International, also organized some capacity training for selected clinical engineers across the 10 regions. I think they selected 2 representatives from each region to train them on servicing of anesthesia machine. These are the key capacity building projects that has been carried out in Ghana. But the Korean Federation is still working with the Ministry of Health and Ghana Health Service to provide some sort of training every year for clinical engineers.
And I know you've got a good
Aside that-
partnership with Canada. I mean, it's not about Canada, it's about you, but you guys have, if I didn't know better, I would say you're not at the low end of the spectrum, you're in the medium, capability spectrum, at least in certain places for sure.
Yeah.
My perception.
Yes. And Canada, that's Gentle. Yeah, they have been organizing some capacity training building in the northern part of Ghana,
Okay.
not in the other regions, yes, but only in the northern part of Ghana. Yeah.
Which
But
reminds me, make assumptions about something covering a whole program, a whole country. It, like you say, it's improvements in some areas, not in other geographical areas. Got it.
yeah.
Okay, George, that's helpful. Fabiola is the team leader, then we'll get to other team members. What are you thinking that you've heard so far today, Fabiola?
Okay, yeah, I think it's we are on the right way to define the future actions. I still insist on having clarity on how to document the case studies in order to them be helpful to measure impact and to define capacity building. Working by regions may be helpful also for having a framework of what is going on in the at different levels, and having insight about what has to be done in order to increase that impact. So if we work on agree about having a general, very a broad methodology to drive these studies and to document them, we may make progress.
Thank you. I know others have been waiting patiently. Go ahead, Luis. Luis Fernandez.
Thank you, Tom, and hello, everyone. Good day, good evening, good night. So I just wanted to point it out when we were talking about the success cases. I was discussing with a couple of Latin American colleagues about the need of, and I told Tom and the CED group before about making a small symposium or forum based on or focused on Latin America, centered on the cases of success. So it's very much what we're discussing now. I did not know the idea about doing a Congress, but this would be this would fit perfectly on what we're trying to do and trying to push, which is we want others to know how our we solving problems all around the world, and something that really is important on a user basis, on people that are directly involved in hospitals and clinics on clinical engineering related activities, is that we do not only want to discuss about what needs to be done or what was done, but rather focus on the how it was done and try to teach. Of course, there's time limitations, etc. But I totally agree on what Fabiola is saying. We need to agree upon what is a success case and also how our colleagues going to document those success cases. Because I as a young clinical engineering profession, what I would need the most, and having in mind that there is limited training on clinical engineering capabilities and competencies at of course a detailed level, is that I would like to not only know what was done and which was the problem that was solved and how efficient it was to execute this, but also how to replicate it. And this was what Frank was saying. There's multiple answers to that question. So I would really like to make an emphasis that on the Latin American side, we are going to propose to CED a small project to build a forum to exactly discuss what we are discussing here, gather most, if not all, of the Latin American societies to present their own success cases, and then scientific committee might select the most highlighted ones, and the ones that were not selected and meet certain criteria will be included maybe on a compendium.
Okay, Luis, I'm going to go on and stop, but I think we got it. Let me just connect what you're saying to what I said earlier. And a Congress that last week of October, Global CE Week. One day of it would be our couple would be the Global Congress, focused just on capacity building, impact measurement, and what we're doing in policy and credentialing. But there's 6 other days, and one of them could be the Americas Day, in the other 5 regions, right? So that's one opportunity for a place to report results, a forum, as you were calling it. But we're also starting regional meetings next month, and America's among them. The Americas can decide, they want to have a forum every 2 months if they want. Or maybe they gather results for 2 months, and the third month, have a halfway, through the year report, but then 3 months after that, it's late October and they present again, more results. So the regions can go any direction they want. And, you're talking about framework and what is success and how to replicate it and training and all that. Those are all good, but I'm gonna give others a chance. Go ahead, Rosanna.
Thank you, Tom. I will use hopefully 7 minutes just to say the bridge to make happen things between capacity building and impact measurement might be probably is a suggestion using a bridge, which is used for the capacity building. And I am, of course, going back to my last intervention in the last session when I pointed about the methodology, and I'm glad Fabiola now is reminding this. It's not just about the professors, not just about the fabulous content selected, but also the methodology. And the methodology is nothing that you just can reply with a special type of marketing or device or a speech. Is something achieved between the experience, achieved with success and also with failures. So I will talk in short, 3 more minutes, I believe,
You don't have 3 minutes now. Are you trying to tell the methodology now?
I am going to finish very soon, Tom, if you may allow me. To use for the context of capacity building, and also after that, the measure of impacts, use priority needs, local priority health needs. It is very noted that it will take all the attentions from the attendees. And I'm talking about successful evidences collected by me and others in Latin America, Central America, and Haiti recently. So once you have these national priorities, could be tuberculosis, COVID-19, oxygen, as you several mentioned, could be also maternal and perinatal health. Those are still very urgent needs, but also affected seriously by COVID-19. And finally, as Elliot stated in the last session, in the last webinar, digital health in many aspects will provide as well, in these cases, some notes and some remarks to make it attractive to the attendees of the capacity building sessions. It's not just about another forum, it's not just about another seminar, it's making the actors being able to make things happen, and it's possible. It's very possible. Thank you for your time.
Thank you, Mohammed from Bangladesh.
Thank you, Tom. Hi, everybody. Since
We can hear you.
several years, we have been trying, and already we make collaboration with our health ministry and several government hospitals and private hospitals and other universities as well. And also the companies who are involved in trading from the advanced to the lower equipment. But thing is that I am agreed with the others that the national priority for that 6 different reasons will vary, and we have to give some specific framework or the methodology that how we will collect more data, so we will find the every areas, especially the weakened areas in the local capacity building areas. So in that case, though we have started some training program, workshop, engaging the expert people in different fields, but still we think that we need to establish collaboration with some NGOs who are working, especially in our region, in our country, for the health sector, so that we can involve with them also and get their feedback to use these data and opinions to enhance or improve our capacity, especially in the first priority in the government hospitals, and then the other private sector hospitals and clinics. So in that case, I think more specific guidance should come from you expert people so that we can use them, and we need more clarity so that we can send our information directly to the health ministry or the other international organizations, especially working in the health sector. Thank you.
Very good. Elliot?
2 quick points. One point is that our colleague Ricardo Silva presented an interesting idea yesterday about creating a formal methodology for ongoing education with continuing education credits for working professionals. And that could be interleaved with a certification or with identification of specific skills like digital health. And I think that that's an area for us to think about, because we really would benefit from some form of cross-cutting international capabilities, both for capacity building and for coming to some consensus on impact. And it's a shame that Antonio is not here. I'm sharing quickly from 2008. Antonio set up a really valuable clinical engineering and health systems administrators, ministries of health people. It was a 3-day conference that also included a number of topics on digital health, as well as managing hospitals administration. And my point there is really not specifically that project, but that we will need, in order to really have a beneficial assessment of impact, we'll need to include leaders from the ministries of health and the hospitals to validate what we are asserting.
Thank you,
Over.
Elliot. George Bordeaux.
Yeah, all right. Thank you very much. I want to make a quick comment, especially on what Luis mentioned about cases of success. Here in Ghana, I'm using an example in Ghana, what is happening here. In my facility where I work, we have medical physicists also in the department as well. And the medical physicists are benefiting from capacity building model from International Atomic Energy Agency. And what the International Atomic Energy Agency is doing is that they identify key areas of capacity, where areas that they want to build capacity. Then when they identify the areas, then what they do is to identify training areas. That is, they have regions. So they have they've grouped them into regions. So they have regional trainings. They've been organizing regional trainings for the medical physicists. And then they've also identified some key institutions that they use to send the medical physicists for formal training. So what they have been doing is they have identified one university in Ghana, University of Ghana, the Nuclear Institute, as their training facility for the region. So they train all medical physicists from the region across Africa. They bring them for training, and then they also send them to the hospitals to do hands-on practical training. So what we need to identify is, one, if we are considering capacity building, what are the areas of focus? Then maybe we identify key areas that we want to build capacity. Then we look for regional experts that have people that have expertise in the key areas that we have identified. And then we do mentorship. And so by so doing, we equip more people on the practical experience, and also that so that we can also, based on that, to measure, use the indicators to measure the outcome of the training. Thank you.
Thank you, George. Brian from Ireland.
Hi, Tom.
Hey.
I won't stay long, just wanted to say, like, I'm happy to be part of the group. Really good to see it. I think I'd be eager to get into some of the detail. I'm a little bit, I won't say unclear, but I would be good to maybe Antonio and the group for us all to get together in terms of the impact measurement. I think there's been a lot of talk about capacity building today, but just to get into the teeth of it, really about what are we expecting to get out of it? What do each of us need to do? And just to get going. So that would be good. So hopefully there might be something scheduled on that. Maybe, Tom, I know you were suggesting either a joint group or separate ones, just to give us a bit of time to talk about the detail of how it might work.
Okay.
The other bit I just wanted to ask Tom was just on the other bits you have on the table, goal 3 and goal 4. Is there any more information in terms of the credentialing piece, what the plan is there for goal 3? Maybe I've missed that.
Yeah, we reported on that before, and you know, there's been a lot of work for a long time. We're going to try to get that started again in April, and you know, you've got a great model in Ireland, and you know, we want to help, you know, make sure the world knows about it as one possible model to follow. So you will be included there.
Great. It'd be good to learn from everyone else as well.
And I think you guys saw in one of the attachments for the meeting that, you know, there's really dozens of subject matter experts around each of these 4 main goals, plus continuing to support WHO be a 5th goal. So we're, you know, going to get a lot of people involved in just trying to herd cats appropriately here. We've got a couple other people on the line that have, you know, like the rest of you have sacrificed to be here. Let me just give them a chance to speak. Carla, you know, a very accomplished clinical engineer, Kaiser Permanente, and then gone into the health IT industry and been a key leader there. Any words of wisdom, Carla? Good morning.
Sorry, I was trying to unmute. You know, it's a big body of work ahead of us, right?
Right.
I'm interested in all of it. I think something that's, you know, at the heart of everything that I'm trying to achieve is bringing, you know, the profession of clinical engineering into digital health. And I think that if we can, you know, have a use case around that, I think it would be very promising. It does really touch all 3 levels. And I think there are some nice opportunities, some areas that we could bring some focus to that.
You're right. It really is among the things at top of mind. And of course, we had that great webinar yesterday where there was an explicit proposal about, you know, both the education and the certifying around digital health for our profession, just to make it easier to take the next steps for each of the practitioners. So we'll particularly connect you and Elliot and Ricardo about that.
And I was just going to say, it's real interesting because I'm doing a lot of work with the rural health communities in the United States and critical access hospitals. And we talk a lot about the United States being very wealthy, right? But we have a significant population in the United States of the underserved and the, you know, the poor, and a lot of, you know, determinants of health that are risk factors where we can't get resources and services and technologies out to them. So there are parallels, right?
Yep.
That I think we can draw from these learnings that we can apply to, you know, other countries.
And, you know, that example of the rural hospital in the US is maybe not exactly what my, you know, Pacific Islands metaphor was a little bit earlier, where, you know, if they had a BMET, then everything would be better if we could get it organized right, but it's similar. So yeah, countries are not all the same across that country, as we're saying. There's elements of low, medium, and high capability in every country, as we know.
Absolutely. And I think a lot of people don't realize that we've got areas where, you know, there absolutely is no pediatrician, as an example. So I live in the Bay Area, San Francisco, California, right? And in Northern California, once you go about 45 miles past my house, I'm actually 40 miles above San Francisco. So about 80 miles above San Francisco, they have to bring in pediatricians on call just to serve, you know, a huge area, a couple counties. And sometimes they don't even have a pediatrician on call. My cousin is one of them that rotates, you know, but let alone the medical equipment, right?
Right.
And yet, you know, even medical services biomed services or clinical engineering technology services. So I think, like I said, there are some real case studies here that we're trying to, make some significant changes and impact that we can, use across the board.
Thank you. Adrian Pacheco, I know from Senatech, and have spoken at our webinars on telehealth, and I know you have a wider view than telehealth alone, which is pretty wide. But any thoughts this morning, sir?
Hi, Tom. Hello, everybody. I think we made very huge or big steps forward. It's going to be a very hard work. But I think if we cannot find the impact that we are looking for, maybe we can show how clinical engineer is related or is in a relation with the health benefits that we are looking for the population.
Very good. I agree. Which is what Rosanna said, got to focus on the local national health needs first as we look at our methodology. Not keeping our favorite masters in health administration. We want to remember Amanda, and Amanda, you got some good thoughts for us.
Hello, everyone. Just wonderful discussion. It's really a privilege to be here listening to everyone. I think the two thoughts that just keep occurring to me are one is like having clearly spelled out the deliverable and having everyone involved understanding exactly what those deliverables are. And two, as multiple people mentioned on the call already today, really focusing in on getting a structure in our methodology, even if a smaller subset of people get together and get some different options or examples. I think having that structure is really going to be critical for this work to make sure it keeps moving forward.
Thank you. And Frank, back to you with me here in Antonio's absence and others of you as you feel led. So we've heard over and over again, we need a framework to, and allow measurement capability, allow data input capability, define what is success, how to do it, what to do, and all that. We've got a few minutes, Frank. I think, figuring out some different models of, at least one or two frameworks, methodologies. I know Sava can contribute to that she's been working on that 3 or 4 years as an academic in some powerful ways, and some of us have helped in the past her with that. But that looks like a next step. In other words, we need to be clear for ourselves, and we need to be clear what we're asking of others in these regions and so forth, what kind of stories, answers we're looking for, Frank.
Yeah, the picture is becoming much clearer that, I'm sort of hoping that the end presentation will be, collective wisdom of this group that applies to, each of areas of endeavor, like capacity building and impact measurement and others in certain areas that we as a group identify need to have advice provided. Dan's example was very good, but it only fills one box of the matrix, and or maybe 2 or 3 boxes of the matrix, because the principles that sort of filter out of Dan's case study are quite beneficial for all of us. Yeah, so it's clarifying in my mind what needs to be done. I guess I'm sort of envisioning a chart, and then each of us have a discussion about each box in the chart, and the notes end up trying to be filtered into a presentation. So, which it's still a long process with a lot of work, but it's beginning to become clarified. Yeah, thank you.
So Frank, I don't know if winter's over in Connecticut, but I'm imagining a couple small snowballs at the top of the hill. They're multi-dimensional. They're starting to roll down the hill. We're adding to them, and they're getting bigger with, you know, in the collection of the ball as it rolls down the hill. And we're, you know, a couple of those snowballs that were at the top of the hill trying to figure out exactly which path for them to take. Sorry about this metaphor. Are certainly pulse oximetry, the UK example, and I think oxygen concentrators clearly at an important, let's say at the low income and at the low capability, but still got to have it tomorrow and today end of things. Ashnafi, I want you to make whatever comments you already had in your head, and what do you think of the relevance of oxygen concentrators as the second case study to consider? Take it away, brother.
First of all, I want to thank you and all the groups who have been just proposing and working on this capacity building issue, because this is one of the burning issue and one of the key areas where we have been waiting for. So I want to say thank you. And I want to also say thank you to Clark for the wonderful presentation and for all the comments. But I have a few comments. The first thing is, when we say capacity building in our context, we have been discussing not only on training, but also on continuous professional development, on education, on short-term training, on empowering clinical engineers to decision making. So we usually give them a leadership training, because we don't have so many clinical engineers in the decision making. So they also have to get such kind of training in addition to the technical training. So when it comes to specific devices, what we have done and what we have been doing in the past 7 or 8 years in Ethiopia is when we procure and when we purchase devices, we expect the clinical engineers to get training in each and every device that we import, and we get either through donation or through procurement. Well, that's one of the areas that we have been working. But the trainings that we obtain from COFI or from USAID and other NGOs, they are just supplementary to what has already been given to the clinical engineers. And CPD, continuous professional development, has begun, and we haven't done so much on that area, but I believe the training on specific devices like oxygen concentrators can be aligned with CPD or other programs, or short-term trainings given by different organizations. But the context we are in, when we identify the low, middle, and high level capacity building, I think we have to also see the context we're in. The context we're in is we're in the time of pandemic, where face-to-face training and capacity building is difficult, where we are obliged and we're forced to use the online or web-based training. And the context in Africa, especially, as difficult pertinent to infrastructure. So I think we have to see if there is any means where we can proceed the way forward with a contextual way of implementing this capacity building program. Other than that, I think it's a wonderful proposal and a wonderful initiative Tom and your group has been working. And thank you very much for the opportunity. Thank you.
Thank you, Ashnafi. Well, in the last couple minutes, we don't have to go exactly to 12 noon on the dot. Frank, it feels like we're going to gather those, as Amanda said, that are explicitly interested in methodology, and the leaders, quote unquote, leaders will join that as able, but not, they don't have to, and we'll try to throw out some models here in the next couple of weeks. Does that sound like the right next step?
Yes, it does. Yep. Very good. Thank you.
And Brother Elliot, he's not the oldest guy in the room, but he might be the smartest guy in the room. Any
Oh,
closing comments?
Perhaps the most bedraggled guy in the room, but I'm just sharing a lot of information in the chat box to download. Just conceptual ideas, things we have done, things we've been talking about, and opportunities. There are documents there from Barbados that is the proceedings that really Antonio deserves the credit for bringing together many different communities and being able to talk about together what our both unique needs and overlapping needs are, which is a sort of a team building and a level of capacity building at the political and community and Ministry of Health level. And also I've provided a copy of Ricardo's draft proposed idea about continuing education units that he floated yesterday during the digital health webinar. He's talking about digital health, but it's really not all about digital health. It really is about providing a framework for structured education and communication. And I've also said that it could be done in a hybrid format, certainly, and we could perhaps partner with Zoom Health if this seemed like a mutually beneficial collaborative activity to also raise Zoom Health's visibility globally. And I'm taking some liberties here because it's not my relationship to offer, but I'm just sort of thinking out loud and dreaming about the things that we might do. And it very closely aligns with work that Antonio has done in the past, and it also closely aligns with work that Frank and I have done in the past with workshops and with PAHO and WHO.
All right, any others before we close for today? Great work. It's worthy and hard work, and we'll all do our best given all of our time constraints. Open
Thank
mic.
you, everybody. You're amazing people
Carla-
to work with. And thank
Carla,
you, Tom.
You got the mic, Carla, if you want it.
Oh, I was just going to say thank you, everyone. I'm sorry to have missed the meeting yesterday. Very involved, as I mentioned, in rural health activity right now. Elliot, I represent Zoom Health here, so definitely can explore that more and set up a direct meeting with Heidi.
Okay, it's I am a secondary player here. I don't want to presume too much. It's just planting ideas for brainstorming.
Absolutely, I think it's a wonderful idea.
And Carla's reminded us that, we put on the virtual Congress last October on a shoestring, and we can do better. I mean, we did break even, but we can, and it's not about making money. It's just about planning ahead so that, we get our white hair a little bit slower. And
Carla,
she's
another
helping us do
definition.
that.
Carla, another definition of LMIC might be low and middle income counties.
Yes, yeah.
All right, everybody, have a great day. We're going to depart for now.
Okay, thank
You're
you.
great folks. Thank you.
Bye.
Thank you very much.
Bye.
Bye.
Yeah, thank you. Yeah.
Thank you. Bye.
Everyone.